Um, Hi, everybody, and welcome back. I always love being the after lunch um, presenter because you're either enthusiastic and ready to get back into it or you're feeling a little sleepy. But either way, I'm excited to be here with you today and Alice as well. So now that we're all stretched out and ready to go, we're going to start with this post COVID, as Alice and I had worked together on this presentation for the first time that we were going to do it, and then we, as everybody knows, it got delayed and postponed and rescheduled a few times, and we realized we wanted to make some changes because what we were talking about before was a little different now that we're post COVID. And as Ann said, we're not really post COVID, but we're post shutdowns, and we're really trying to figure out what can happen. But it's really thinking when we think of what happened to patients during the real the shutdowns and not having visitors, and people were afraid, and there was a lot of we had to step away a little bit from the patient experience and what matters to patients to looking at what matters for the entire community, and to do what was considered best under very, very difficult circumstances, and circumstances that we hadn't faced before. So as we look forward and moving ourselves forward in healthcare, we can really start to think about what matters in a much broader way, um, and including obviously what matters is a patient focus, but really thinking about everybody. We have had a lot of stress and trauma happening to everybody in healthcare in this past year.
So, one of the things that we always think about, that I think all of us think about when we are caregiving in any situation, is how do we help people feel better, heal better, and be as safe as possible? And of course, that's the focus today. The work that I did at Concord Hospital from 1989 until I retired last year in 2020 really focused on how do we help people who might be feeling anxious, lonely, bored, confused. How do we help them feel calm, at ease, and at peace? Because those, we believe, are keys to safety and to healing. I do want to mention, and I'm very grateful that Dana Bisson earlier mentioned many aspects of therapeutic arts and holistic services, and I'll briefly just give you a very quick overview so you kind of have an idea of what I'm coming from. I'm an art therapist by profession, um, and therapeutic arts and holistic services evolved over 31 years, focusing on all patients in the medical and surgical units of the hospital, initially including pediatrics as well, but a focus on adults and certainly older adults. Over the past 10 years, very much involved as partners with clinical staff in preventing and mitigating delirium when it does occur. We also worked with newborns with neonatal abstinence syndrome and their parents, with people with substance use disorders who are mostly younger adults, but not exclusively, people with pain, anxiety. And among the services that we provided are Reiki, which many of you know is a form of energy healing that originated in Japan, aromatherapy, both to help mitigate uncomfortable symptoms, anxiety, nausea, pain, headache, even lack of appetite, and also for post-op nausea and vomiting, which was found to help diminish the use of anticholinergics and other anti-nausea meds. Post-op, we had live therapeutic music, which Dana mentioned briefly, pet therapy, a lending, an framed art print lending program, which I'll mention briefly again later, televised bingo, and also individual activities that included everything from therapeutic horticulture to art making to helping people write their autobiographies. So all of these were with the goal of comfort, with decreasing use of medication when possible, especially for pain and sleep and anxiety, and really with a focus on avoiding high risk meds, and helping increase engagement, mood, motivation, and participation in care. So you can imagine how that would be well integrated with delirium prevention and management. So again, we come back to this question: how do we help our patients feel better, heal better, and be safer when uh, when they feel calm, at ease, and at peace is really what we always want to do. And so I ask you for a minute to just imagine yourself. Just imagine that you are unexpectedly admitted to the hospital today or tomorrow or tonight, and something has happened, um, and I want you to think for a second and just write down briefly what is most important to you. Just take a brief minute and write that down and really think about what matters to you as a person. And Tanya, you can advance the slide. Um, so think about it, write something down. What matters most? We can go to the next slide, Tanya. So hopefully all of you have taken just a moment to write something down, and we're going to do a quick poll. Tanya, you can place that on. All right. So we are thinking about the different categories that most of those fit into. My care, my activities, my things, my relationships, my values. And take a look at what you wrote down. If you wrote down one thing or more than one thing, and just think, what is it most likely, most closely fit into which of those categories? And then just hit submit after you've clicked on one of those.
And when you see the most people have answered, you can close it and it'll share the results.
Can you see me sharing the results?
Yes. So it looks
Okay.
like 59% my relationships is where most people's what matters most fit into. Second, my care at 21%. Do you want me to go on, Alice?
Yes.
Okay. So we're going to come back to what matters to you. But as you can see that there's a variety of categories that the family, that our participants have fit into. You saw this earlier with Marie, um, the IHI, What Matters to Older Adults toolkit. And there is a lot of back and forth. You heard sometimes we're talking about end of life and what matters and preferences across healthcare as a whole. So this is a great resource for everybody. But today, Alice and I are going to go a little bit beyond what we're thinking about when we look at the categories. We start seeing relationships was much higher than care, and many of you or all of you are healthcare workers. So if you were looking at um, if we did the same poll with people who weren't working in healthcare, care might even become less. So it's really thinking about today what matters to people, and thinking that this is not a static thing. What matters to me at this moment, what matters to me at a particular given time may change time to time, and it's going to be very different. So, right now, I have a bad shoulder that needs to have surgery, but it just became spring and I have a pool outside and I get about 10 minutes of the year to swim in that pool. So surgery isn't going to happen for me because that's one of my favorite places to be. It's not going to happen. I'm going to delay it. So that's what's important to me at this moment. But come winter, my pool isn't going to be what's the most important. And that's not to diminish that I have family, et cetera. But in a moment for a particular diagnosis or care plan, what is important to somebody is going to change, and it's not always going to coincide with what the staff or clinicians want. So if if there's a feeling that my shoulder is better off being taken care of sooner than later, well, that's a discussion we need to have. So it's really respecting what is important to a person, even when it goes against what might be clinically considered clinically best. Oops. So there is some evidence to this concept of what um, is important to people. And the Barrel Institute does, believe it's biannual surveys of patients and families about their experience. And one of the questions that they have is when you think about having a good patient family experience, how important is it to you that the people providing care do each of the following? And this was the categories that they had. And there's a lot of different ones, and but the top one consistently time after time, this one was done in October 22, but always at the top is listen to you. How important is it? What's important is that people listen, and listening to what matters to people is maybe one of the most important things. The second being communicate clearly in a way that you understand and provide a clear plan of care and why they are doing it. Those three have consistently been at the top. So let's take a minute and think about what matters to you. And you all had, we saw that the relationships were in there. And if you want to chat in some of the pieces, sorry, some of the things that you put on your list, you're welcome to do that. We'd love to see it. But really, what matters to you, Alice, what stood out for you when you saw the survey report results? Is Alice muted?
Thank you. Exactly the same thing. That for so many people, it's about the relationships, the people who support them, the people they take care of. When somebody is hospitalized, one of the greatest concerns that they mention is who will take care of my husband. Right now, he's struggling while I'm not here. I'm his primary caregiver. Or who are going to take care of the kids or the grandkids or my cats? Those relationships are often so much at the top. But as Tanya said just a moment ago, it shifts sometimes by the day, certainly by the situation. And we have to ask that question over and over because it's not always the same.
Yeah, so, and thank you. Is it Cheryl that says, listen, 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 having viable choices, two-way communication. So you're all reflecting what the Barrel Institute found in their data of having somebody that listens. And I would say that if we took patient complaints and really boiled them down to it, it is about not being heard. Okay. So what matters, IHI has been doing this for a long time, and it really is across the country. There is a lot of discussion about it. Um, we heard earlier about whiteboards being used in the rooms, and whiteboards have, for a lot of different reasons, for goals and clinical stuff and what matters. But thinking about whiteboards, we heard from Marie that, and I've heard from so many patients that, yep, there was a whiteboard and it was across the room. I couldn't get to it. I couldn't read it. I couldn't add to it. But really thinking, if it's a communication board, how is that communication happening and how is it two ways? But it's a great way. And this is a great article where they really just have in it the entire board that you see is what matters to that patient. So when we think about this whole idea, we're going to go through all of these, but I want to stress, and I know Alice feels the same way, is that this really is just human to human interaction. So we're going to go through it as if there's many, many steps to it, and there are, and there can be, but really think about it is, and just how it is about connecting with other people. So the first thing is asking what matters. Alice said it. You can ask this question a lot of different ways directly. So this is my mother, the little girl in the birthday hat. And this is her mother, my grandmother, who is by far, no offense to my mother, but my grandmother is by far my favorite human. She's no longer with us now, but she still remains my absolute favorite person. And this picture is my mom's third birthday. And my grandmother had raised her on her own from birth, because right after they got pregnant, my grandfather was sent during the war to Panama. And so he had never seen her. Um, and my grandmother took care of her by herself. And here they are. They got reunited. My grandmother took my mother to Panama, again on her own, to meet up with her husband. And they spent the next couple of years in Panama and have always shared great stories. And the reason I'm sharing these is many, many years later, when my grandmother was in her late 80s, she's hospitalized and I'm bedside. And the nurses are coming in and they're talking to her about her care plan, and they're talking to about how she's a fall risk and that she needs help, to not try to go to the bathroom by herself. And she agrees that she's going to call, and she is very, very agreeable. And then the nurse leaves, and a few minutes later she's starting to get out of bed. And I'm like, Grandma, where are you going? What is going on? And she's like, I need to use the bathroom. And I was like, well, let me help you, or let me call the nurse. And she says, I have been going to the bathroom longer than you've been alive on my own, and I'm going to do it on my own here. And what I realized many years later, at the time, I just did what Grandma told me to do, and I sat down and she was safe and she did not fall. But when I realized how much of a fall risk she was, I realized that what was missed is, this is a very independent person. She was doing things um, that women just didn't do. She was traveling across the world. She was taking care of her daughter on her own. She was maintaining a life um, for her family. And so she saw herself always and forever as the women, the two pictures that you see here. She did not see herself as a frail person needing help to do something as simple as going to the bathroom. And so it's asking what matters is also understanding, how does somebody see themselves? What do they see that is important to them? There are so many places, this list could have been much longer, of how, when you have that conversation, so that whether it's outpatient or inpatient, but really thinking about when you have that conversation and who you have it with. Because my grandmother would have told you that she uses no assisted walking devices, that she walks completely on her own. But if you had asked me, I would have told you that she does walk on her own in her house, where she has all the furniture laid out so that she's never has her hand off of a piece of furniture. So, really thinking about what matters to her. The patient might not have this, um, the ability to tell you, but the family also can. And again, it's asking the question a lot of different ways. What is important to you at this moment? What goals do you have? What is it? Why is it that you want to get out of the hospital right away? What is it? What does a good day look like? Or what do you fear most? Whether that's about the procedure or about heading home, what worries you the most? So, really thinking about a conversation, not just a checkbox of I've asked them what matters. Everybody can ask what matters. Anybody and everybody can. And again, what's not on this list are people that we might not think of as having this conversation, because who do patients often talk to the most? The people that are coming in to change the trash, to bring them food, to clean up their room. So really thinking about who are the people in the organization that can have time to sit down and really have a conversation and find out what matters to that patient.
And I'll add to what Tanya said. It's a matter of having time, but it's also a matter of trust. And I love this picture. We chose this photo because really one of the things that you see here is how do we develop trust? Certainly, people following through on things, people really being present. But in the moment, one of the ways that trust happens is the demonstration that you are listening attentively and fully with your full heart and your full mind. So not only are we paying attention, but we have to be curious. We have to want to hear the answer. When we're listening, if we're not curious, it goes, it's a matter of rote and it's just going through the motions. And you won't get the truth from people. People have to feel that they can, that person laying in the bed has to feel that they can trust you with what is deepest to their heart, and that you're not going to judge them, you're not going to advise them, but that you're just listening. And one of the ways that that happens and that demonstration happens is through, sometimes through silence, sometimes through gently prompting and asking for more, but squaring your body so that that um, plane of your body faces theirs fully. You're not turning away and typing on your computer and entering into the EMR. You're not turning to walk out of the room. Your hands are still. You're not doing other things with your hands. But when you're having that conversation that's important, you want to listen to the stories and you want to show by making eye contact and through silence or prompting that it's about them and it's not about you. I remember a gentleman who was in the hospital. This was probably about 25 or 30 years ago. Um, and he had been admitted to the hospital for what he thought would be a brief stay. He had abdominal pain. He had been living with his stepdaughter's family, and the family took that opportunity as a time to say, now that he was out of the house, we're not really going to be able to take our stepdad back anymore. So Charlie was in the hospital, had abdominal surgery, and then a long hospitalization while he awaited nursing home placement. And so we talked almost daily, and he had great stories. He was a wonderful storyteller, and I wrote his stories down as he was telling me, which he really enjoyed. And I said, I think we're writing an autobiography here, and I'll be your hands. So I would prompt him with certain questions. At the end, we had a 26-page autobiography, and the most compelling thing about the experience for me was not just his stories, which ranged from meeting Babe Ruth as a boy in Boston. He was born in 1912. Charlie was, and stories from the war. But the stories of his life and his relationships, the most compelling thing was that at the end of each story, he would ask me to read it back to him. And it was only when I read it back to him that he wept. And he did that every time. And one time after weeks of this, I said something like, Charlie, that was a light, fun story, but I see it made you cry. And he said, what makes me cry is that you're listening to me. You really heard it. You heard the details. And that was what was so important to him. That was what mattered to him, was being listened to. We can move on to the next slide, Tanya. So some of the things that we hear from people when we ask what matters, and sometimes when we don't even ask what matters, is the littlest things and the biggest things. So it might be something like, I feel calm when my hair is brushed gently. When someone says that, there may be a subtext here. What's between the lines? Well, maybe the person is telling you that they're not feeling calm, that they're feeling anxious or stressed or in great distress. So you want to listen to the words and also try to understand what's underneath it. And as you know, I wrote these examples, and as I do, I'd like you to take a minute and think about if this were your patient, how might you respond when someone says, I feel calm when my hair is brushed gently. Now, you may not have a lot of time to sit there with a brush and brush out their hair, but maybe you can just give a gentle stroke on the head, asking permission first, of course. Someone who says, I prefer to take as few drugs as possible. Well, maybe you have some alternative interventions. In Concord Hospital, it might be aromatherapy or live therapeutic music or Reiki, or finding other ways to help people mitigate the symptoms that they might receive some PRN meds for. Someone who says saying my morning prayers helps, it gives me hope and it helps me start the day right. Give them time, give them space, maybe close the door and put a quick note on the door that says, please don't interrupt until 9:15 after prayers are done. Someone who says, I grew up in the Depression and I hate to waste food. That might be someone, you just order small portions. You start noticing how much food they have left over at the end of a meal. And so it's not only important for the efficiency and cost efficiency of running your facility, but also thinking about what really matters to that person who is distressed by wasting. Someone who says, don't speak to me like I'm a child. And that's something, of course, that we've heard too many times. And that's something that we are all in control of. And the next comment is something that probably all of us have heard, and we certainly have been acutely aware of this in the past year during COVID hospitalizations. And of course, we all know that there are some people who do prefer to wait till they're alone, till the family leaves the room, and that's when they finally pass on. That has been of greatest concern. I think about Marie Cleary Fishman this morning and her story about her dad, and it reminded me very briefly of when my mom, at the age of 91, was brought into the hospital with ischemic bowel, and she needed to have surgery immediately, or she probably wouldn't have lasted the next couple of days. And when she was in and out of alertness and able to communicate only intermittently. And when the surgeon finally came and said, what do you want us to do about surgery? The family was torn because she had already suffered a lot in the years before that. And she said, if I have the surgery, will I be able to go to my granddaughter Lily's wedding? This was the thing that made it possible for her to say yes to a surgery that she knew would she might not survive, and that if she did, it would have a very difficult recovery. That wedding was the thing she was living for. We're ready for the next slide. So when we think about what matters, we listen, and sometimes we can take action. In those examples that we gave just a moment ago, there are many things that you can do that, in addition to documenting, which we'll talk about later, there are many things that you can often do. And then there are many times that the best thing that you can do is to reflect. And I'll give a couple of examples. This is when someone talks about something, we ask the question, what matters to you? And the person answers. And we can do what matters. And sometimes at Concord Hospital, especially at this time of year, people might say to me, and Tanya, you can move on to the next slide. Someone might say, the thing I miss the most is being out in my garden. I just wish I were there to do the weeding and do the planting and see those flowers. And so, of course, during a hospitalization, we weren't able to bring somebody out to their garden, but we could, in a way, bring the garden to them. And so, by having a collection of plants, and in our office, I always have cuttings that were rooting in water, and I always had clean potting soil. And again, here's another way of running a program without spending any money. Every year I sent an email to a couple of hundred staff at Concord Hospital and say, bring in your 4 to 6 inch plastic pots, run them through the dishwasher first, and then deliver them to our office. So we always had a supply of pots and cuttings, and we would just bring it over to somebody's room or have them come to our room, and somebody could, maybe they're learning how to pot indoor house plants, or maybe they're just taking care of it. Not only did it give them a half hour where they're engaged in something that is not medical, and they can smell the soil and their hands are focused on, on the tiny little details of the roots of the plants, but they also they feel restored by that feeling that they can take care of something other than just being the passive recipient of care. And I think that metaphor is a perfect example of what matters. For some people, it might be the garden, it might be taking care of the dog or your children, but people often become very passive during hospitalization, and having an opportunity to take care of something else is a great antidote, a great balance for that feeling of passivity. Another example that comes to my mind, this was something I couldn't do anything about. So what could I do? I could listen, reflect, and encourage. This was a man named Bob who wound up at Concord Hospital um, during, maybe 3/4 through a year where he and his wife were sailing around the world in their yacht, on their sailboat. And he was visiting someone in New Hampshire as part of their travels, got very sick and was admitted to Concord Hospital. And he became known among the people who were taking care of him as Bob the Sailor. But he said, really, what I want to do is just be back out on my boat. And so I brought in from home a world atlas. And every day I visited him in his post-op period, and said, show me the places you've been and tell me, what would I need to know if I were going there? What was your favorite thing? And giving him a chance to reflect on it was so important. And then there's my mother-in-law, my beautiful, wonderful mother-in-law. And this is a picture of what she looked like much of the time. This, very briefly, I'll just tell you that when she was about 84, she was hospitalized, had emergency surgery. And the next morning, when the surgeon came in to check on her, she had curlers in her hair. And the surgeon said, Mrs. Kinsler, I've never seen anybody with curlers in their hair in the hospital. And she said, I've been doing this since I was 16 years old, and I'll do it as long as I'm breathing. So if you're taking care of me, this is me. And then, how did she get those curlers? Well, of course, leaving for the hospital, she said to her husband, my father-in-law, make sure you bring the curlers. So what mattered to her? How people saw her. Experiencing beauty every day was a crucial part of her life and her identity, and how she spread her graciousness and beauty to everybody else. So what mattered to her was, Tanya, if you can hit that button, we had her family. Well, in her case, when she left for the hospital, her husband grabbed her curlers and her lipstick, and everyone in the hospital noticed how she looked, because when she took those curlers out, here's what she looked like. And she was an extraordinarily beautiful woman. And it's because of the effort that she made. And that's because that's what mattered to her. So So we ask what matters, we listen, we do. If it's not actionable, we can reflect on what matters and give people the opportunity to make the most of what it is that matters. This is kind of a framework or paradigm that I always used with my volunteers and interns, um, a little mnemonic to help them think, how do you help people reflect? How do you help them be the most of who they are and make the most of what they can in the moment? So, healing presence, I always ask this question: how can I use my presence at this moment now, to help this person feel more whole? Recognizing that when someone is hospitalized, or if they're in a long term care facility, or if they're in the ER, something has broken in their lives. How can we help them feel more whole by using our own presence? And as Tanya said earlier, it's that human to human interaction that is really at the core of how we can help someone, especially someone who's frightened of being alone. And then also encouraging self-expression, helping people engage, helping them be the most of who they are. And when we say encouraging self-expression, certainly as an artist and an art therapist, for me, self-expression might be creative, it might be the visual arts, but that's not all there is. When we encourage self expression, we are giving people space to be themselves in the biggest way possible. And especially during hospitalization, people are feeling very small. They feel like a, a little speck in this gigantic institution where things happen that are difficult for them to understand and impossible for them to control. And self-expression really means being who you are as much as you can be. Bring up to the surface what is that core, that seed inside the person that makes them who they are, the sum of all of their experiences, their preferences, their passions, their relationships. Also, remember the impact of being in a foreign environment and how off balance people feel. Next, giving your attention and thinking of the ways that we can take action and the ways that we can help them take action, encouraging patients to be active participants in their care. I think for some people, one of the hallmarks of depression and giving up is when people become very passive. So let them be who they are. And then language. Language is verbal language. It's listening, and it's also very much body language, which we talked about a little bit earlier when we talked about listening. But using language that the person understands, that makes sense, that's connected, taking into account if they have dementia, if they are in acute delirium, how will they understand you? So it's verbal, it's nonverbal, it's that whole picture together, and it's the mechanism by which we relate to each other. And that includes eye contact. And Tanya, I'll let you take over the next part.
So, as we talked about, there was a lot of discussion today about documenting what matters and really integrating it. Whiteboards has been the go-to for what matters, for sharing information between amongst the clinicians and staff and other people that come into the room. As you can see on this is a great whiteboard. It has all the pieces, but as I said before, and what we've heard is can this be seen from across the room? Is there information? And it has family and patient questions. This is a pediatric example. But and it has an all about me section, but really thinking, are we using the whiteboards? Does everybody use it? Is the patient able to use it? And is there really space on it to put the things that are important to the patient, whatever those might be? Um, and the idea of what matters could be what matters today, what matters to you at this moment, and thinking of ways to post that in the patient rooms. And it's great to hear that there's talk about having what matters as part of the electronic medical record, because that makes it an easy way to be shared amongst people. But really thinking if everybody that goes into the room has this, like, I'm going to take note of what matters to this person today. Stories about what matters. if you were to listen to Alice and I putting together, we spent hours and hours together, and most of it was sharing story upon story of what Alice has experienced with her patients, what just my experience as a patient, Alice's experience as a patient, and all our family's experiences. Stories really stick with people and what matters to somebody. So using those stories and specifically for a person, but also sharing it, how it incorporated, sharing how bringing an atlas in to somebody whose trip was interrupted made him feel connected to that part of who he was, and felt like, I mean, that's a person who's now going to trust his healthcare team in a different way, who's going to be more relaxed to do that. But sharing those stories of what's been done. Um, Patients and families we've heard about too is really including them. And I see in the chat this balance of our desire versus our desire to keep somebody safe versus their desire to be vital or independent, as my grandmother. And so there's is clearly a tension there, right? But we can look at it, but by having a discussion, we can figure out that this is what matters to somebody. And so, what do we do for somebody who wants to be independent and feels confident going to the bathroom on their own, even if they're seen as a fall risk? Patients and families can be a huge help in that. Um, I don't think we use patients and families at the bedside, and this year we've probably seen it, and we probably can shared lots of stories of what has happened because there was nobody at the bedside. But really thinking of patients and family as and families being anybody that the patient considers family. So who are the people that are really part of the care team? Update the care plan to reflect what matters. So if the patient has a clinical, what matters to them impacts their clinical care, to have that in there. And then, as we've said over and over, have daily conversations, maybe every shift, of what is mattering, what matters now, and then update is. So the idea here again is to really integrate it into what the patient's care plan is, but also into the culture of the organization. And I said at the beginning about staff, we can't be teaching our staff and clinicians to ask what matters to our patients if they aren't being asked by their supervisors within their organization of what matters to them.
So we come back to these five very broad categories. They're not set in stone. They're, as Tanya and I talked and planned for this presentation, we realized that everything we talked about kind of seemed to fall into one of these. You know, the activities, someone who is uh, a golfer, someone who's a musician, someone who just wants to play with her granddaughter. Those are the activities that are sometimes at the core of a person's life. A gardener, someone who knows what they need to feel whole. The things that people have. For somebody, and I'll use my mother-in-law again as an example, her home was an external, an exterior reflection of her inner life. Calm, beautiful, serene. Anyone who came into that home felt good, and that was the presence that she exuded. And for her, she might say, first she would say her family, but of her things, material things, her home would have been way at the top of her list because of that, because it was her. It was her. Relationships, which we've talked about. Values, I think for my father, who's approaching 97, his observance of his religious faith and traditions is probably the most important thing. And giving him the time and space and the materials he needs to be able to do that, help him feel whole. And then, of course, my care. And we've talked about that a lot. Marie and Ellen both talked on that so importantly. What are the goals of care, and how do we help somebody receive the care in the way that makes sense to them? Really, I think all of these come down to what helps a person feel like himself or herself, despite the current situation. Tanya, we can move on to the next slide very briefly, and then we'll move ahead. Human connection is really what matters to all of us. We are human beings before we are patients. And we live in a social world and a world with other people. Um, so, sometimes I remember in my early years working at Concord Hospital, I might hear someone say, um, the hip replacement in 6034 or the gallbladder in 518. And this is a good time to remind everybody that on one hand, we want to be efficient in our speech when we're communicating at work, but no one is ever their diagnosis. And this man is not colon cancer. This man is a person who has colon cancer, and his identity is key. Tanya, we'll go to the next slide. One of the programs that I mentioned that we have at Therapeutic Arts and Holistic Services at Concord Hospital is called Art a la carte. We have a selection of well over 100 framed art prints and a hook on the wall in just about every room. And the intention is that the person laying in the bed gets to choose the art that they want to look at. And so my favorite print happens to be this one on the left, which is called Morning Shadows. It's a beautiful print. And it one of the reasons that that print is so popular is because it takes people to a place where they want to be. Now, I know if someone chose that print, it's because they like the beach. And I know that because the program is created for the person laying in the bed to choose the print, now I know that Mrs. Smith, who chose this print, is a beach lover. And when I come in to change a dressing or put in an IV or take vitals, I can say, "Oh, Mrs. Smith, I see you chose that picture of the beach. That is beautiful. Tell me about your favorite time at the beach." And so while I'm changing that dressing, which I know causes her some anxiety because she's had pain with it before, I'm debriding a wound, whatever, she can be talking about that, and that's what she's thinking about. And that brings her to the things that connect her to. Now, most hospitals don't have a program like this, but you can certainly say, while I'm changing your dressing, Mrs. Smith, tell me about your favorite place to be. So at Concord Hospital, since 2005, when we started this program, I have found that to be one of the most popular prints, but it's not for everybody. Maybe you had a traumatic experience at the beach sometime. But when I give this print out, I always say, "Oh, and I look at this, I imagine the wind blowing through my hair and those shadows early in the morning. What would it sound like with the waves in the background and the seagull? You know how the sound was muffled by the sand at the beach?" And make it a full sensory experience. Engage the five senses whenever you can. Now, I don't know if any of you watching, in attending this conference today are cat lovers. I bet many of you are, but this was one of the other most popular prints. And it's not just because it makes people smile, and how can you look at that and not smile? But when people love cats, it's part of their identity. They don't just have a cat or take care of a cat or cuddle their cat. That's a cat person. And when you walk into a room at Concord Hospital and you see a print, we probably have 10 different prints. We have, you walk into a room and you see that hanging there. You can say to the person, "Are you a cat person?" And you're sold. The rest of the relationship comes easily, and it's easy to understand why. It's the identity. We can move on to the next slide, and I'll just tell you a quick story that came along with this. This is one of the slides that we have, and I would think most of you would recognize Elvis in this slide. So I said this is one of the slides we have. This is one of the framed prints that we have. And one day, a gentleman chose this slide, and when he hit this print, and when he saw it, his face lit up, and he said, "I haven't talked about this in a while, but in the early part of my career, I was an Elvis impersonator." And the volunteer who was bringing the prints that day said, "You were an Elvis impersonator. Tell me about it. What was that like?" And he spent 45 minutes just talking about this was the favorite time of his life. And when that print got hung up on the wall and people came in, he got to point across the room. It was facing right opposite the foot of the bed. He would point to that and he'd say, you know, I was an Elvis impersonator. And he went from being, the guy with the infection in his, shoulder replacement, whatever it was that he was there for, he became this Elvis impersonator once again, and it filled him. He filled the bed, he filled the room with his personality, and it was just a beautiful thing to see. So patient satisfaction, of course, diversion, of course, but it's about identity. When you help a person know who they are and remember who they are, you help them know what they want to get back to. And that's what matters in hospitalization. That's that's what they're there for. They're there to become the person that they've always been once again. And we help people do that by reminding them and helping them hold on to that person that they've always been. So to sum up, we will have some time for question and answers. If there's extra time, I would love to tell you the story about this lovely, lovely woman, but we'll just use it now to break for question and answers, and to say to all of you who are watching and listening to this wonderful day today, that we hope you always have what matters to you. And thank you. So questions.
I think you've stunned them all. I'm looking through the chat still. Well, everybody needs an Alice.
That is so true.
If we can clone you. Love the idea of the photos on the wall. Let's see.
Alice, while we're waiting for questions, why don't you share the story?
Oh, the story of Rosina. Okay. So I know when this happened because my daughter was 2 years old when Rosina was in the hospital, and now she's 31. So it was a long time ago. I was asked to see this woman who, this was another complicated bowel surgery. She was very depressed. She kept her face, her head under the blanket day after day. A nurse asked me to go see her and said, can you figure anything out for her? And so I went the first day. I told her very briefly what I did at the hospital. And she looked out from under her blanket, just a tiny bit of eye, and that was it. The next day I came back again. She only said, I just want to die and go to the cemetery. And I came back the third day and I reminded her that I had been there. And when she uncovered her face, I could see that her face was covered with hair. This woman had not had a haircut, not had her bangs trimmed in years. It was, her hair was just crazy. You couldn't even see her face. And I very impulsively said, I think you need a haircut. It wasn't my place to do that, but I, I just was a person seeing a person. I said, I think you need a haircut, which shocks me now that I said that. But she pulled her face out from under the blanket and she said, you would do that? And that was not my intention. So now I was in it and I said, I guess I will. So remember, this was 1991 and rules were more relaxed, I guess. I ran back to my office. I grabbed the only scissors I had, rusty, old, heavy metal, like kindergarten paper, teacher paper, scissors kind of thing. And I brought back a sheet and a towel and a pillowcase. She sat up on the edge of the bed for the first time in 4 days. I covered her with the sheet and I just cut her bangs. And she beamed and she said, keep going. I wound up giving her a haircut. And if you can see, this picture was, I'm not exaggerating, this picture was taken 24 hours later when she was out of bed, talking, rolling a ball of yarn to start crocheting, showing off her haircut. She wound up, and they're in another room right now, but she wound up making 2 blankets for my babies. And for a lot of other people on the floor, she was in the hospital another 6 weeks, smiling every day. And I believe that it's because somebody just saw her as a person, and that's all she needed. And it was a coincidence that a photographer was coming the next day to do a story about the work that I was doing, and got this picture of her. So it was a great lesson for me. I will never forget her.
I think Alice, I mean, so many of your examples, um, what is most touching to me is that you have these thoughts and you go with it. You didn't try to figure out who should you is this the right thing? What should I do? What's the procedure? But really
I didn't get
responding.
fired, Tanya. I thought that was a very
Well, definitely. So, but it's really knowing, like feeling in your gut what is the right thing to do with somebody. I have a great story of a nurse who had a patient who was so stressed out, and the there's lots of details to it, but she was so scared that the nurse actually held her, like lay down with her because she was in a fetal position and scared. So it's not that everybody should cut everybody's hair or that all nurses should lie down with their patients, but it's really in that moment understanding what does this person need. There was a question, Alice, about the how you got all of the art prints.
sure I can tell you about that. Um, So I ordered them. I did all the ordering, and I didn't choose necessarily what I liked. I chose what I thought over after years of working with people, what would be most popular. And there are several websites, including allposters.com or artprints.com. If you look for cheap prints, you'll actually find many. We have Monets and Van Goghs and impressionist work and Cezanne, as well as pictures of kittens and puppies and Elvis. So having a wide variety is important. The frames, I bought a standard size frame so that when we hung the hooks in every room, we knew that they would fit there. So they're all vertical, 22 by 28, and I bought them in bulk, 10 at a time. And I think when I started buying them, they were probably 14 or so dollars a piece. They're probably more now. They're plastic, there's no glass on them, and there's no metal. I actually, because they're not expensive, they could come apart. So when I got them and I did the framing myself with the help of volunteers and interns, um, I only bought vertically oriented, portrait style prints because they had to hang vertically to fit into the space. So I would very often either mat them myself or crop them. And after I framed them, I would use, this sounds so chintzy, but this has worked for 16 years, black duct tape on the back to hold the frames in place. And I use fishing line to make it easier to hang on the wall. So all in all, it was quite inexpensive. We did get a couple of donations. In fact, when one of the vice president of facility operations at the hospital retired, he made a donation. He and his wife made a donation to that program so that we could expand it. So we got donations. I would say it's one of the most popular offerings that we have. And we probably served 1,700 patients a year in a typical year. There were two ways, I'll just say one more sentence about this, two ways that people could get art a la carte. And one of them was we had a sign hanging right under the hook in every room that says, this space is for artwork. Please call extension 3895 if you'd like to see our selection. And we'd get that phone call and we'd run with the cart. And then the other way is that when we had volunteers available, which of course has not happened this year, but has happened in all of the previous 15 years of this program, volunteers would go door to door. They'd knock on the door, offer an opportunity to select an art print, and then people would choose. And of course, they could decline as well. And of course, we have a system of inventory and tracking what we have and cleaning everything. sometimes people who were on infection prevention or infection control precautions would have prints. And so, of course, they needed special cleaning afterwards. But it was available to every patient in the hospital. I hope that answered that question. Yes, baseball images. We have baseball and football, snowboarding, skiing.
I just want to throw out too we heard earlier Anne mentioned about having stuffed animals to donate. Is some of these things, people love to donate things, and you can get a lot of donations of things versus money, or somebody feels like I'm not going to donate my $20 or $50 to the hospital. But when they can go out and buy a couple of stuffed animals or some poster prints, etc., I've seen a lot of success with that, putting it out into the community as well. But that is our time. This was great. I'll stop sharing.
Thank you so much, Tanya and Alice. And I just want to highlight too, Christine Howard had commented that when she was a med-surg nurse, given her background as a hairdresser, that all her patients had great hairdos. And I'm reminded of yesterday, there was a presentation by a peer support specialist within our behavioral health program. And he talked about the fact that he was in school to become a nurse, and he was torn by the fact that he thinks being a peer support specialist might be kind of more fun. But the fact is, he will bring that peer support specialist concept into his field of nursing. So hopefully all of us are drawing upon our own skills and strengths. And Tanya, thank you for commenting about the donations. I wrote a list of things I want to bring to the hospital now, so hopefully they'll be accepted. So we're right at break time. Everybody's staying great timeliness today in terms of staying on time. So we have a 15-minute break.
And I'm sorry to interrupt. If anyone is interested in seeing how we do those puzzles that Dana talked about in the ABCD cart, I'll show that during the break. It'll take just 1 minute.
Great. And you'll also show your fidget?
Oh, do you have the, okay, we'll talk about that after everyone goes to break.
I'll try and bring it up. Okay, so you're on break. If you want to listen to some more of the artistic talents of Alice, you can stay with us. And then Hannah, I'll come in to you shortly.
Okay, thanks, Anne. So I'll just mention about the puzzles, that there were, puzzles are expensive. And of course, we are all concerned about preventing the spread of infections. So we do everything with single use. That means that to sustain the program, it has to be very inexpensive. So we had kind of, in the ABCD carts, we have 2 levels of puzzles. Those for people with mild or moderate delirium, and those in severe delirium. The ones, I brought 2 examples. These might be used for people with who are in kind of a mild delirium, not someone who is acutely confused. We simply glue them with a glue stick to cardboard, the same kind of cardboard that would be at the back of a legal pad or a letter pad, and then we cut them up. And so these we would cut up probably into 7 or 8 pieces. For somebody in severe delirium, we use a much simpler picture. And this image I cut, these are all, by the way, from calendars. And Anne Diefendorf has donated many calendars to Concord Hospital, but this is a perfect example because it's a singular unified image. So, and in fact, the original calendar picture was like this, and it was much larger, and I trimmed it to fit onto a piece of 8.5 by 5 inch, like a notepad. And then I simply, I cut it. I marked it on the back where I would cut it. And it winds up being a 4-piece puzzle that, so here are the 4 pieces. We put them into a plastic baggie, and we put them in the ABCD carts. And then if it's 2 o'clock in the morning or 3 o'clock on a Saturday afternoon, a nurse can take it, and or an LNA or a family member, and help the person focus. But in a case like this, because it's such a simple image, you can simply say, put the bird back together. So it's not a complicated puzzle. It's putting the bird back together. So for people who are in a more severe delirium, choosing images that have a central singular image that is distinct from the background is important.